right, psychiatric rehabilitation. Um, we have the psychiatric rehabilitation process, diagnosing, planning, intervention. Psychiatric rehabilitation is a component of mental health. Psychiatric rehabilitation is a helping relationship. It's a helping interaction. Psychiatric rehabilitation is a recovery-oriented service, functional assessment, resource assessment. Close the door. Required recordings. One of the required running records for the psychiatric rehabilitation process is assessing and developing readiness, choosing a goal, functional assessment, resource assessment, rehabilitation plan, intervention schedule. Patients should work towards recovery in the life that they deserve, their choice of a productive lifestyle. Psychiatric rehabilitation is a helping interaction. Example program model for psychiatric rehabilitation is the clubhouse model, which for psychiatric rehabilitation work is a concept of focusing on strengths and not deficits. It's an idea that we can all contribute to this community. Clubhouse promotes socialization and support with maximizing available resources. ACT, assertive community treatment. That basically means we're coming into your house and helping you. We're a team of professionals thinking of how to help this person. Maybe they have schizophrenia or something like bipolar, they need that additional support. We always want to be a principal leader with psychiatric rehabilitation. We're focused on continuous improvement in the implementation, practice, and study of psychiatric rehabilitation. We're always doing some form of tracking versus recording in the psychiatric rehabilitation process, and our consumers matter the most. We're in a consumer service industry. We're in a customer is always right industry. We are practitioners, which means we're constantly looking at our practice and observing and listening and responding to what's given to us. Psychiatric rehab started back in the 70s and the 80s as a response to deinstitutionalized people from hospitals coming into the community. The rehab attempts to open the doors of the community and help people figuratively develop a prescription for their kingdom lives. Psychiatric rehabilitation services are collaborative, person-directed, and individualized. Psychiatric rehabilitation helps people determine the living, learning, working, and social goals that they want to achieve. Consumers of mental health services can learn to implement, supervise, train, administer, and do research on the psychiatric rehabilitation process. Psychiatric rehabilitation has introduced a new outlook on mental health across the world. So psychiatric rehabilitation services are collaborative, they're person-directed, and they're individualized. Psychiatric rehabilitation helps people determine the living, learning, working, and social goals they want to achieve. Consumers of mental health services can learn to implement, supervise, train, administer, and research even in the psychiatric rehabilitation process. I told him to cut the water off because it was making that sound. Yeah, I didn't say to do the eggs. He cut the pot off? Those are still, I got a timer on for the eggs. They still got 6 minutes. Psychiatric rehabilitation has introduced a new outlook on mental health across the United States. Mental health concerns usually runs hand in hand with poverty. So if you have poverty, you're probably going to find mental health concerns. Psychiatric rehabilitation focuses on the promotion of recovery, full community integration, and just improving the overall quality of life. Our services are collaborative, they're person-directed, and they're individualized, which focus on an approach to support. We must ensure that there's cultural competence And there's diversity, equity, and inclusion in everything that we do. Psychiatric rehabilitation has 7 domains that they need to keep in common. The first domain being, you done with your work? You done with your work? There are 7 domains for the performance standards for psychiatric rehabilitation. The first domain is the interpersonal competencies, basically known as the communication skills for the recovery process. Okay, so what are the interpersonal skills that we need in order to effectively communicate with key stakeholders? Secondly, how do we switch up communication when needed? So when your interpersonal relationships are failing, how do you switch up your communication to make sure that they succeed? Domain 2 is professional role competencies, also known as how to stay sharp and skills relevant, how to stay sharp and how to keep my skills relevant in a professional and personal setting. We are advocates, okay? Meaning we stay sharp with our updated skills in the field. We manage and deal with personal stress and ethical dilemmas, and we balance our work. Okay? We'll always being advocates. We're always bringing into new ethics. How do we increase ethical considerations dealing with people in recovery? We are always here to help people in recovery. That's the goal. Domain 3, community integration. Just knowing all of the community resources available to my clients in recovery. I think it's very important that we don't use medications as much as we use resources. Right? Improving skills around connecting people in recovery with the resources that are readily available to them. Community integration, placing an importance of community resources, maintaining their use, and keeping clients aware of resources. Very important. Domain 4, assessment, planning, and outcomes. Also known as what must I know in order to help people in recovery? With the goal setting and the planning, you have to know the people first before you can support them. Everything comes back to the goals. We use goal development and readiness awareness to support assessing and reassessing. Developing systems to keep track and maintain an individual's changes and needs as aligned to psychiatric rehabilitation services provided. Domain 5 is the strategies for facilitating recovery. What can recovery treatment and intervention strategies actually look like? How do we develop them in partnership with community people in recovery? So how can we connect those that are like our peer support groups, right? Those proven models of success. How can we foster that? We must know how to speak and how to use effective tones when we're communicating people with recovery, because we want to inspire change in our people to recover. How group work. We want to talk about how group work works for recovery. How does crisis response work? How can leadership development help promote recovery and its importance? We need to know the common types of psychiatric rehabilitation interventions, such as employment support, educational support, housing and residential support. Those types of supports will facilitate the recovery of that person. Domain 6 is systems competencies. Basically also known as our psych rehab advocates must always focus on using skills to increase advocacy, reduce discrimination, increase access to community resources, decrease the negative effects of poverty, and increase services for people in recovery. We need to be aware of the systemic changes that impact public resources and policies. We need to be thoughtful of recognizing opportunities for nuanced recovery, creative advocacy, and how we use it, and how we communicate. Domain 7, last but not least, which is important, I think is the foundation, is Domain 7, which is supporting health and wellness. Okay? Health and wellness have a critical part in psychiatric rehabilitation work. We need to incorporate wellness competencies and plans to incorporate psychiatric recovery through health and wellness, like fitness. okay? By using the 8 dimensions of wellness, which is emotional, physical, social, environmental, occupational, physical, spiritual, and financial. Are you just looking at it right now? That's so funny. So financial. So the goal is, if every day you wake up, you do one thing inside of each of those 8 buckets, then you are living a complete, fulfilled life. So we have to make sure that we use the 8 dimensions of wellness and learn certain skills and attitudes that we need to be successful in those domains, in those dimensions. We need to also incorporate WRAP, which is Wellness Recovery Action Plans, in partnership with clients and supporting their wellness and their psychiatric recovery. It's a lifelong journey, and this is an ongoing event. All right, there are 4 negative impact stages on mental health. The first being an impairment. It's always impairment, dysfunction, disability, and then disadvantage. The impairment is the delusions or depression, which is lack of psychological help. The second is dysfunction, lack of work skills, social skills. Third is disability, which is lack of ability to do the normal. And the fourth is a disadvantage, which is a lack of opportunity. Okay. The consumer involvement and shared decision making is very important. Outcome accountability for providers, making sure providers are delivering top care, addressing the effects of poverty and discrimination, improving role functioning, which is PRP, versus symptom relief, which is kind of treatment, versus accessing needed services, which is case management. So, accessing needed services, case management, symptom relief is more treatment, and improving role functioning, that's the psychiatric rehabilitation process. As far as the essential services, kind of works its way down. Treatment helps with symptom relief. Crisis intervention helps with personal safety assurance. Case management helps with services accessed. Rehabilitation helps with role functioning. Enrichment helps with self-development. Rights protection helps with equal opportunities given. Basic needs support is just personal survival assured. We just need to have our basic needs met. Self-help is empowerment. And wellness and prevention is all about just your overall health improvement from the major 8 areas of your life. It's really all on the person being committed to their own personal growth. Okay, we can do whatever we want to do, but if they're not committed to personal growth, then you're going to see less than optimal results, if any. It's super important to have customers set their own goals. I can't repeat that enough. It is super important to have consumers set their own goals, because that's going to make it more likely that they achieve those goals. People are more apt to change for the better in the context of a positive relationship. So our clients, they don't need to be told they're doing the wrong thing. They need to be told they're doing the right things. What things are they doing right? Focus on the positive. People change for the better when they set their own goals, because it's owned, it's autonomous. People change for the better when they are taught skills. People change for the better when they are given support. People change for the better when they have hope for the future. People act for change for the better when they believe in self-efficacy, meaning they believe in their ability to change for themselves. Again, PRP is a helping relationship, okay? Meaning that we're advocates, okay? It's on the left side is the practitioner, on the right side is the consumer. In the middle is love, it's heart, okay? The efficacy of this intervention hinges on the relationship of the practitioner to the consumer, okay? Practitioners must be a skilled listener that's empathetic. The highly debated topic is the importance of relationships now in relation to successful outcomes in mental health recovery. As we know, relationships is the foundation, is the key. Medicaid is the joint federal state providing health coverage. That's what we operate under, Medicaid. One of the tools we use for consumer satisfaction is the recovery promoting relationship scale. That's something that we can give to our clients to just make sure their voices are being heard. It's very important. As far as Medicaid, the federal government defines the guidelines and the state determines the allocations and the benefits requirements. Medicaid offers other diagnostic screenings. They offer preventative help, which is huge. That's what we want to focus on, preventative help, and rehabilitative services. Psych rehab reduces disabilities and it restores functions to where we want to be. Medicaid and PRP focuses on the ADLs, the activities of daily living skills, independent living skills, social skills, communication skills, self-care skills. How are we coping? How do we manage our household? How do we manage our budget? Skill acquisition and utilization occurs best when the tasks are approximate in the real environment in which they must be used. Real context matters. We want to build skill development within real context. Medicaid services can be furnished in any location. They can be given at home, they can be given at school, or they can be given in the community somewhere else. Psychiatric rehabilitation is easily tracked and recorded, which is why it's Medicaid friendly. Everything is about the readiness assessment or developing readiness, right? Creating that functional assessment, that needs-based assessment, starting those goals aligned to the consumer, and then creating those skill development within context of whatever those goals are. So it's very easily tracked and recorded. You want Medicaid personnel to do a good job of checking to make sure that the psychiatric rehabilitation is actually happening, okay? Whether or not there's progress being made towards the goal. That can only be determined through the tracking and recording, which is why it's so important. Medicaid only pays for healthcare services, so you have to be very careful that what we're doing is aligned to healthcare. The service has to be medically necessary, medical necessity. Symptom treatments and deficits support. Diagnose, plan, intervene. Diagnosis, plan, intervene. Very important. The tracking for psychiatric rehabilitation, we must keep track of everything that we do for consumers, okay? We want to hit the laid out steps that bring the consumer closer to the preferred service outcome. These benchmarks are key because we can't just jump to the last step as the measure of success. Service delivery has to move in a logical and expected manner. Service delivery has to move in a logical and expected manner. Tracking in itself is important because it answers the consumer's questions of how's it going, what's working, what's not working. Outcomes could be years down the road, but we still need to know, are we moving towards that? The practitioner itself benefits from the tracking by being made of effectiveness or a need to change up interventions. You can't know if something's effective unless you have data to prove it that is not or it is. Tracking lets supervisors know what supervisor sessions to focus on. Tracking lets the trainers know that they can isolate areas to focus on for specific trainers in the future. Tracking let admins know how to adjust certain systems to support positive gains. Tracking lets funders know how can they observe where their money is going. And tracking lets researchers know so that they can obtain certain key data to push experiments that can promote recovery in our global community. It's all about DPI, diagnosing, planning, and intervening. DPI, diagnosing, planning, intervening. DPI, diagnosing, planning, intervening. That's all of the service delivery process is. All right. Interventions are an art just as much as a science. You have to be creative. You have to be able to think outside the box sometimes, because people are people. They're not robots. Okay. The diagnosis, planning, intervention process of psychiatric rehabilitation is one that's consistent across the country. The diagnostic phase is set out to self-determine the consumer's readiness for rehab. The diagnoser which is also called the practitioner, sets the goal, then evaluates his or her skill levels in attaining said goal. The diagnostic also captures present resources available or resources that are needed to achieve optimal life. So, does this person have a house? Does this person live in a safe community? Right? Those are checking the resources to make sure, and the environmental to make sure that they're good. The diagnostic findings are what drives the planning portion. Okay, so the planning cannot happen without the diagnostic. The diagnostic collects the data, and that drives the planning. Okay. What happened? Move fast, Mason. What? Jeez, I cannot. The goal of a treatment plan is mainly focused on reducing symptoms. The treatment plan specifies the how in developing the psychiatric rehabilitation goals and their aligned skills. The intervention phase is the implementation. Okay? Intervention's goals is to change the person through skill development or environmental shifts. You should have an annotation on each part of the text. All right, intervention's goals is to change the person through skill development or environmental shifts. So if you put a person in a different environment, the odds are they will change their behaviors. If you teach someone how to do something, odds are they will change their behaviors. Okay? So diagnosis, planning, and intervention, it assesses rehab readiness. If not, then develop their readiness. You set the overall rehab goal, you provide the functional assessment, the resource assessment, and then you start planning for the skills and resource development. Okay? Direct skills teaching is very important. Skill use programming is important. Resources coordination is important. Okay? Tracking is tedious, and I get that, but it's necessary. We have to do it. It's how we're able to keep a record of what we're doing. In the diagnostic stage, you want to do the readiness assessment. You want to do the readiness development. You want to set a self-determined goal. The functional assessment, meaning what can they do, and the resource assessment. What do they have access to in relation to that goal? Is that going to be successful because they might not have the resources? So that's very important. And then in the planning phase, we want to develop a rehab plan to improve skills in relation to that said goal. Developing a rehab plan to improve supports. Okay? In the intervening phase, direct skills teaching, meaning we're learning new skills. Programming skill use, overcoming barriers like preventing goal attainment. Resource coordination, that's the intervening, right? In order to intervene, you want to coordinate the resource. Intervene, you're teaching the direct skills. Intervene, you're using the programs. Also, modifying and accommodating the resources that they have. That is a form of intervening. Because if the resources that they have are not applicable or beneficial to them, then they need to be adjusted. Okay? PRP is a process used for people figuring out their goals, what they want to achieve in their lives, in their residential lives, in their educational lives, in their vocational lives, and their social lives. And our job is to develop the skills to support them in reaching that goal. Okay? Goals, skills, supports. Say it with me. Goals, skills, supports. Okay? We're always diagnosing. Always diagnosing. Always. Always seeing, is this working? How is this going? How can we improve? That funnels into our planning, which obviously will dictate what interventions we use. Okay? Now, in the diagnosing phase for case management, you're just going to be setting service goals. You're going to be looking at strategies. You're going to be reviewing daily functioning. Okay? In the planning phase,
You're going to be formulating a service plan. You're going to be supporting clients and creating that plan, okay, for case management. And then for intervening for case management, that's when you're providing a case management service. Like, you're actually linking them to services, you're monitoring their service use and things of that nature. For health and wellness, diagnosing might be different. Diagnosing might be assessing a fitness status, setting health and wellness goals, right? The planning portion is formulating a health plan and supporting that client in that planning phase. And then intervening with health and wellness, that's just developing good health behaviors for people, developing resources to support people's healthy behaviors, supporting the use of healthy behaviors for people. Now, what we love is enrichment. We love to help people's lives to go from good to great, okay? So for diagnosing for enrichment, we're looking at identifying enrichment needs and values, evaluating and choosing enrichment options as part of diagnosing. And then you want to schedule the enrichment activities, right? You want to schedule the client and how they interact with each other for those activities. The intervening part is actually delivering the enrichment activity, accompany someone to that enrichment activity, right? Walking them into the doors of that AA meeting that they might not be so comfortable going to for the first time. And support during supporting during that enrichment activity. Maybe you're not sitting next to them, maybe you're just in the hallway and they can come out and chat with you if they feel some type of way. But just being there for them, okay, that's very important. All of our services at Serenity and Grace are tracked using the DPI process. All of them, okay? When we record the PRP services, what is actually happening, that is actually being tracked and going to be shown for quality assurance. Tracking lets people know it's a positive track and progress, whereas recording lets you know what's actually the progress is happening. Okay? So tracking lays out the tracks, recording fills it in with what we're doing. Record keeping is knowing the result of what has been done and what has transpired. A readiness assessment and development is a record that must be always a readiness assessment, and a readiness development is an assessment that we use in order to support people in becoming ready for recovery. The consumer's self-determined readiness has to be recorded, and the rehab goal has to be recorded. Basically, everything has to be tracked and recorded. Okay? A readiness assessment helps people figure out their immediate willingness to participate in psychiatric rehabilitation services. Okay? So we always give a readiness assessment first to make sure that they're ready for it. And if someone is not willing to do it, then we need to create a series of readiness development activities. Okay? The readiness development activities should follow if they don't want to do the readiness assessment. So we're never giving up on people. All right? Readiness, as classified, is based on a need for change. Like, they're just pissed off for greatness. They're pissed off for what is going on in their life. A commitment for change, meaning like their higher self-belief, like this can be done. Personal closeness to a support buddy. So a buddy is very important for someone to go through in a situation in life. Self-awareness, meaning aware of their past choices and the impact of them. And emotional awareness, open to new people and places. Like, are you open to new experiences in life? Okay? The three categories for readiness is, are they ready, not ready, and unsure. Okay? Ready, not ready, unsure. Okay? Now let's talk about setting goals. Let's talk about this whole goals thing. All right? All right, let's go back to it now. Thank you. Goals. So example of a goal would be to live in blank supported apartments until August of next year. Another goal would be to enroll in a special education program at blank community college for the next spring semester. Another goal could be to work in XYZ employment program for 6 months. Another goal could be to attend this church drop-in center on a weekly basis by next January. Okay, so goals really are aligned to what the person's specific desires are. Non-negotiables when setting a goal. Our goals usually are from 6 to 24 months. The environment in which they choose to live, environments they choose to live, environment they choose to work, environment they choose to socialize always have to be included in that goal. So the time frequency, the location, has to be there. Okay, so we're always looking for the environment and the timeline. And like I said earlier, goals must always align to the person's values, their core values. Okay, environmental goals are evaluated against consumers' unique personal criteria. All right, their territory. How are you impacting your territory? We got a functional and a resource assessment. The functional resource assessment, its overall goal is pretty much the name of the title of the assessment, is to assess their resources and to assess their functional skills in relation to what they are trying to do. A functional assessment records the evaluation of present needs in relation to the skills. Okay, so if the goal is to walk a mile, and the functional assessment discovers that, you know, this person struggles with putting their shoes on or wearing proper shoes, then we need to focus on that skill to help support that goal. But that's a function, right? Skills and supports have to be observable, measurable, and objective as possible. Okay, so the number of times per week that the consumer converses with family at a dinner table, that is a goal that we can track. The percentage of times per week the consumer speaks in a calm manner when they are upset, that can be tracked. The number of days per week a relative can drive the consumer to a college campus, which builds relationships, right? That can be tracked. The number of job leads per month that someone can provide the consumer, or the consumer can follow up on, that can be tracked. These are all frequencies, and these are all measurables by the frequency of said thing. Pretty much the functional assessment names the critical skills, the resource assessments identifies the critical supports. Okay, so functional does critical skills, resource does critical supports. What are the resources that you have available to help support you? Functional, what are the skills needed in order to be successful? All right. You want to really be judging on whether you really want to judge on whether or not they are the clients committed to change or not. Okay. One of the worst things you can do is try and force someone to change. Change has to happen on the part of the person. They have to desire it first. If they're not willing to change, then you need to start creating readiness development activities to get them to want to change. The first thing you need to decide is, are they committed to change? A lot of people act like they want to have change, but in reality, they're not really that committed. So when we set a overall rehabilitation goal, we want to answer this question constantly: where do I want to live, work, or socialize successfully and happily in the next 6 to 24 months? That's very important. Okay. In a functional assessment, we need to ask ourselves, what do I need to do to be able to do well in order to be successful and satisfied in my goal environment? Like, what are list the critical skills that they need for this environment? Describe the skill use. Evaluate skill functioning in relation to that environment. And then as far as the resource assessment, what are the things, people, places, or things I need to have to be successful and satisfied in my goal environment? So listing those critical resources, describing resource use, evaluating resource use. Okay? So what do I need to do? What do I need to be able to do well in order to be successful? And what are the people, places, or things I need to be successful? Functional and resources. All right? As far as assessing readiness, how willing is the participant to actually engage in rehabilitation? Some people just don't want to do it and they want to stick in their funk. Leave the assessment alone and start working on readiness development. So you need to develop them to be ready. Now, we still have diagnosings, planning, and intervention. Okay, that's always going to be the case. The goals of psych rehabilitation are recovery, community integration, and quality of life. All right. There are certain psychiatric rehabilitation principles. The first one, psych practitioners believe all can recover, learn, and go. Practitioners are aware of culturally relevant material. Practitioners incorporate shared decision-making with patients' input as a priority. Practitioners focus on the strengths of the client. Practitioner services are always person-centered. The psych rehab focuses on getting people serviced in their community. Psych rehab promotes empowerment and client voice within their recovery. Psych rehab promotes the development of a client's personal support network. How are you fostering your personal support network? Psych rehab helps a client social, occupational, educational, residential, intellectual, spiritual, and financial. The 8 areas of wellness. They support that. They help them with that. Psychiatric rehabilitation also promotes health and wellness with an individualized wellness plan. Psychiatric rehabilitation promotes evidence-based best practices and quality assurance with clients. Psychiatric rehab services must be readily available and have the least path of resistance. This is very important, okay? This least path of resistance. Anything we do, any support we give, we always want to be asking ourselves, is this the least path of resistance? Or is there something better that we can give that will give more autonomy, more onus on the person, more of an opportunity for us to increase efficacy for that person. So you want to make sure that your interventions and your direct skill building is always aligned to the least path of resistance. Okay. As far as principles for the youth, they're pretty much the same. They're going to be done in a spirit of partnership and a spirit of collaboration. And those goals for the youth are also going to be driven by the desire of the youth's goals, whatever those goals are for that youth. A couple of the principles are 1, hope and respect. 2, culturally relevant. 3, shared decision making. 4, strengths-based. 5, family-centered. 6, community integration. 7, empowerment. 8, natural supports. 9, quality of life. 10, health and wellness, right? So developing lifelong habits. 11, evidence-based practices or emerging best practices. And 12, accessible and coordinated. So making sure that everybody can access these supports. Okay? At all times, we should be maintaining the highest ethics at all times. Okay? Integrity is a core value of ours, and we take that serious. All right? Psychiatric rehabilitation promotes recovery, full community integration, and an improved quality of life. This is for people who have been diagnosed with any mental health condition that seriously impairs functioning. Psych rehab services are collaborative, they're person-directed and individualized, and an essential element of the human services spectrum and should be evidence-based. They focus on helping individuals develop skills and those individuals access resources so that they can have an increase in their capacity to be successful and satisfied in the living, working, learning, and social environments of their choice. Very, very important. Okay? There are some basic assumptions of psych rehab. One of them is recovery is possible without a professional's intervention. That's an assumption, okay? It's also an assumption that people need folks who believe in them and stand by them. That's an assumption. Your theory really means nothing when it comes to promoting recovery. That's an assumption. Recovery can occur even with the presence of symptoms. That's an assumption. Recovery work can help the frequency, duration of symptoms. That's an assumption. Recovery is not a linear process. There are a lot of ups and downs. That's an assumption, okay? So you should assume all of these things about psych rehab, that it is possible without a professional's intervention, that people do need people to believe in them, that it really means nothing if you're not promoting recovery. Recovery can happen even when symptoms are present, okay? Recovery from the consequences of the illness can be more severe than the impact of the illness itself. Meaning an illness can hit you harder, but how the illness impacts you and relates to your day-to-day life might be 10,000 times even harder. Okay? We also want to distinguish between impairment versus the 3Ds: dysfunction, disability, and disadvantage. Okay? Impairment versus dysfunction, disability, disadvantage. Recovery from mental illness does not mean it was never there. Okay? Recovery from illness does not mean it was never there. Personal support is paramount. Okay? It's paramount. We gotta have personal support. Everybody needs a champion. Dr. Rita. Okay? Quality assurance tracking. Relationship building, which is unique. We always want to do quality assurance on a relationship building because that's very important. Right? Mental illnesses have a catastrophic effect. And sometimes you don't even recognize it in the moment. Okay? So the belief factor is critical to recovery. It's critical. More than anything now, we need creative programming. Okay? Sometimes denial of information can prevent clients from becoming overwhelmed. Information can be seen as a bomb or a blanket. Harsh and hostile versus warm and welcome. So how you deliver that information is very important, okay? It could be a bomb or a blanket. Denial does not mean non-functional, okay? So just because I'm denying my condition doesn't mean that I don't have the skills to be successful in recovery. Emotions don't come with mental illness versus emotions happen due to engaging in the recovery process. Our vision is always geared towards recovery, always. Okay? 1990s was like the decade of the brain, where people started looking at the brain, and it really became the decade of recovery. Stamping on what actually constitutes recovery is a big thing nowadays. Okay? We always need to incorporate hope. Our goal is the independent living movement. Mental health issues are simply challenges a person can grow beyond. You have to know that. You can grow beyond this challenge. Okay? Equality of opportunity, full community participation, independent living, economic self-sufficiency. These are all ways that you can have an independent life fulfilling for yourself. And this is what we want for our clients. All right? Empathy is very important. Empathy, in fact, is critical. It's getting in the hole with somebody. We must adapt and be able to empathize. Let's learn something about this person. Empathy is putting yourself in someone's shoes. Be aware that most things are subjective, so you can't speak from a place of your personal experience. You kind of got to project into their space. Take my own temperature, right, before I get that. And sometimes if you're upset, you got to just step back and let it go. Okay? 2 men stared out from behind the prison bars. One saw regrets, and the other saw the stars. So however you want to look at that, perspective is everything. Our reactions are tied to our beliefs and our feelings of things. So you want to grieve through the reaction. Okay? You want to disengage if necessary, you want to process the situation, and then you want to impartially then select a course of action. With empathy, is 3 things. ASS. Actively listen, share similar experiences to build the connection, and then you want to see what they see, and that'll allow you to see what they see. Okay? The one linchpin for any successful relationship is unconditional support. Okay? You need to truly befriend your client and give that unconditional support. There is something called the Rogerian argument, which basically finds a way for both the consumer and the practitioner to win. You align your message with their needs. You gotta find the linchpin. Where is the source of this emotion coming from? So we can get to the unconditional. We can create the unconditional environment that I won't quit on you. We have to change ourselves before we can change people that we service. Okay? You have to build a consensus. We both can win in this situation. All right? Let people know, hey, is this an external locus of control or an internal locus of control? Because that's going to let you know whether or not you can handle the situation or not. And as always, adaptability and high efficacy for self are critical components of empathy. Creating collaborative relationships, it starts with finding a common ground between people. You can't build common ground if you want to go left and they want to go right. Y'all both need to decide we're gonna head this way, and then what that's gonna look like, sound like, and feel like. Okay. Part of that is communication. Again, actively listening, ask questions. You definitely want to think about this relationship with an interpersonal lens. Look at this relationship with this work that we're doing with an empathic lens. Have a heart. Simple. Have a heart. We don't treat mental health, okay? We don't treat mental health. We support growth. And that's very different. That's a very key nuanced shift that we need to have ingrained in us, okay? Mental illness operates through behaviors, okay? Mental illness operates through behaviors. So you got to be patient with people. Their behaviors is going to manifest their mental illnesses. Recovery, again, is non-linear, okay? It doesn't just go left to right in a straight line, right? It's up here, it's circling back, it's going forward, it's moving this way, it's up, down, and we're still moving, right? But we might be moving one step back, 2 steps forward, 2 steps up, 3 steps back, 1 step up, 4 steps back, 5 steps up. It's subjective to whoever it is. Just like in basketball, you want to set small goals to build success, okay? So when you're starting out with a client, set small goals that they can attain so they can start building up that success muscle so they can be wanting to dive into deeper, more rigorous goals. Okay? What is everything? Hope. Hope is everything. What is everything? Hope. So we have to be the role model of hope. We have to show hope is within us, around us, and through us. And just to break down that Rogerian argument again, it's being the referee, right? You validate their side. You don't misrepresent it. You validate it and you dig deeper. And you do a fair tone when you do that. You use fair, calm tones, and then you find common ground. It's consensus, not compromise. Compromise means somebody's going to lose something. I don't want that. I want us to come together. We can both win here. Okay? Something very important is the people we deal with, they sometimes don't look at themselves as leaders and champions. But you need to take people as they ought to be, not as they are. Okay? So you lean in and you be authentic to the moment. You look at someone as what they ought to be, not what they are. And sometimes when someone's telling you something and you don't know what to say, you can just say that. You can say, whew, I don't even know what to say right now, but I'm glad you told me. And just right there is like everything you need, and it helps everything to make that person feel better. You have to remember that everybody is unique. Everybody's unique, and the relationship is the floor. Okay, so I really want us to drive this empathy. So you're concerned with the internal feelings and the perceptions of people around you, right? Empathy is seen from the inside of the person. The expert is the client, to be honest. You're not the expert as a practitioner. The expert is the client. They've been living with this mental health condition long before they got diagnosed with it. And they know how to go around. They know how to use it. They know how to support themselves. So find what that is, okay? Their thoughts and their feelings, their perceptions are important. That's data. You have to understand them from that platform. Then you treat. So know them from there and then you treat. The relationship is the floor of empathy, okay? You build background knowledge by diving into literature, culture, talking about the community. We can measure empathetic understanding based on 5 levels, right? Don't come in too hot. Come in level 3. Don't come in, ease how you come in. The principles of multicultural psychiatric rehabilitation is culture is central. Culture shapes all of life. The culture of a building is going to let you know what that building looks like and feels like. Practitioners are aware of their own culture and their own selves so they don't create biases and start discriminating. Practitioners also push to understand the relevant culture updates that we have in society. Stay on top of things. Practitioners' thought patterns and behaviors are influenced by culture. People's thought patterns and behaviors are influenced by culture. Practitioners must pledge to eradicate discrimination. That's something that we can't do, something we can't use in our field. We must also apply the strengths and the wellness approach. Strengths-based approach is looking at what someone does well and attacking them through that. The wellness approach is looking at it through those 8 dimensions that we talked about. Financial, occupational, spiritual, social, emotional, mental, physical, and environmental. And then practitioners also want to accept that cultural values and push solutions through the values. Okay. Now we had our code of ethics. At the end of the day, the code of ethics is a guide. The fundamental values and principles that we use. We want to respect everyone with worth and dignity. At the end of the day, everybody matters. Ethical behavior is the key. You should not be eye for change at the end of the day, right? You don't exploit people. You don't do fraud. You have integrity. You give people freedom of choice. Okay, so we're always thinking collaboration and always person first. We'll also talk about justice. Social justice is very important. And then you want to have respect for diversity and culture. Everybody's culture matters and diversity matters. So let's talk about community integration, which is huge, right? Which is what we want. The goal is to connect everybody back with society. The types of organizations that we see can be nonprofits, for-profits, community-based organizations. But it doesn't matter, spiritual-based. We just want to connect people back with society. All right. When we bond people together, it's inward for the private good. Bridging is outward for the public good. Right? You want to bridge out. Participating, contributing, reciprocating in the community. That's huge. Increasing our people's social capital. Everybody say it with me. Social capital. So social capital represents the resources available to individuals through their relationships and their memberships in the community or organizations that make your life better. Think of this guy loans a lawnmower, even if the blades come back dull because the neighbor watches his dog for him, right? So he doesn't say anything. The benefits of social capital is increased longevity, higher self-reported physical and emotional health, lower levels of crime and violent crime, improved community problem solving, and better economic development, which makes sense because people are supporting and benefiting the community, right? They find value in the community. Community integration is the opportunity to live in the community and be valued for one's uniqueness and abilities just like everybody else. Now, obviously, the problem with social capital is that people who struggle with mental health issues are usually isolated and have poor health, and have more poor health, okay? If I have depression, then I'm not the type of person that's going to loan my lawnmower out, so then I can't have somebody watch my dog. So you see, it's like there's this trickle-down effect of the mental health preventing somebody in the communities from really using social capital as a sense to help gain their life and recovery. Community memberships involves participating, contributing, and reciprocating. What are you giving back? Okay. Providers have to provide opportunity and the encouragement for participators persons to participate in these events. What does that mean? You need to practice community inclusion. Okay. Welcome and incorporate people with disabilities into the community as they are. Social integration is critical. Everyone deserves to be able to pursue the good life, just like everybody else. Okay? The average USA citizen feels impeding loneliness happening, which has been exacerbated by the pandemic. Okay? There are two service pathways of psychosocial rehabilitation. The first pathway is rehab treatment, which is, improved functioning, symptom reduction, and unfortunately, more resources are given to that side with the whole rehab and symptom reduction. But more resources should be given to the other side, which is community engagement. That's another service pathway. So one service pathway is rehab and treatment, but the other service pathway is community engagement. I can attack your mental health diagnosis through bringing you and reinserting you into the community just as much and effective as I can attack your mental health as providing you with treatment and best practices of rehab. Okay, but the community engagement, which is also known as community membership or social participation, is not valued as much. Okay, like for example, only 15% of staff resources goes to building community relations, where all the rest of the money might go to staff development. But we need to build up those external community partnerships so that people can start living fulfilled lives. We need a real social network for clients at the end of the day. Okay. Thinking about the recovery-oriented assessments, best practices, we always want to make sure that people are in a good place to take an assessment. Okay, so you want to assist the person to align their strengths with their goal setting. You want to perform holistic assessment across life domains to identify strengths and barriers. Find ways to decrease professional supports and go to more natural supports, right? We want to decrease professional and move more natural. We need to collaborate. As a practitioner, I need to deeply understand a recovery-focused assessment versus some other assessment. Assessment is the first step, and it goes on continually. We're always in a state of assessing. You're always assessing the consumer. You're never not assessing. We assess to set goals and to create intervention plans. The assessments will help monitor progress and evaluate the outcomes. So in order to determine eligibility for consumer services, we have to assess. So the assessments needs to be recovery focused then. We need to amplify strengths rather than deficits. All right. We take assessments through talking and watching, self-reporting interviews. The components of assessment in psycho rehab, for the person, it's going to be assessing rehab readiness, assessing functional strength, needs for desired role. For the environment, we want to make sure that there's no barriers in the environment. It's a safe place that they can take the assessment. They feel comfortable. It's not too cold, not too hot. Okay? Now, sometimes before we dive into recovery, we want to make sure that this person is ready, right? So there's rehab readiness, which is basically capturing the person inner faith on recovery. Simple question. Do you want to change? Not asking like that as triggering, but do this person wants to change? Okay? You want to be motivational. You want to be inspirational when you're doing this. You want to ask them deep questions, open-ended questions. You want to use prompts like, tell me more about that, or can you explain that more? Can you go deeper into that? And you really want to just push, that you're committed to them and you're committed to this work with them. We need to figure out the consumer's focuses and preferences, because that's obviously going to drive recovery success rate up. As far as community integration, we really want to map out our neighborhood. So where your client lives, and then start mapping out what resources are around them so that they can start to have that kind of infrastructure of their own lives and their community to be successful. My consumers should expect the same treatment as normal people, right? They should also be able to pursue valued adult roles. They should be welcome into the community. Recovery is for community integration. That's why we're recovering, to get back in the community. You want to push them to recovery by pushing them to the risk of recovery. Letting them know that recovery will be risky because, it's vulnerable. But they can do it and you're here with them. You want to focus on the fact that we want to push universal best practices, which is friendships, okay? You want to integrate them in the community because part of community integration is developing friendships. You need to know which community involvement choices are prudent, all right? And which ones are best for us. You want to be a positive gatekeeper. Be a bridge. Connect people to things. There are 3 beliefs for success. In order for someone to believe, in order for you to believe in someone to be successful, you need to first appreciate that person's individual gifts. You need to actively try to build community for them. And you need to trust that that community will be impactful for them. Okay? Now, we have challenges, obviously, in this work. And those 4 challenges, the service of choice, right? I need to teach my people to use their talents in the community. Employee of choice. We need to promote volunteering. Neighbor of choice. More love shown between neighbors. More reciprocity between neighbors. And then organization of choice. We have community building. We need to recruit volunteers. An example of service of choice would be an employment academy where you do job shadowing or classroom experiences, where you teach social skills, social integration. You help with their social appearance. Okay? Being a positive gatekeeper means respecting the people in the group, respecting the influencers. Okay? By being a positive gatekeeper, when people come into that room, when people come into that group, then you're transferring validity to that new member. If I'm a gatekeeper of my group and everybody respects me, and then a new person comes in and I give them respect, then that person now has gained a little bit more respect because of how much respect I have collectively from everybody else. So you need to be that positive gatekeeper so that you can open up the doors to let people in so that they can feel supported, regardless if they don't have that time spent for reciprocity or for just, I know this person, so I show them love, whatever. Then you want to find the passion. Then you want to find the passion of the consumer, and then incorporate them into a social group. Okay. Making meaning is crucial. You've got to make meaning. That's very important. You make meaning by identifying the community passion, and then you engage local organizations. Okay. Link the consumers with the active community-based organization. Link the consumers with the active community-based organizations. We need to be committed to community inclusion. Okay? It's all about reciprocity. All right. The problem that we face with psychiatric rehab is people can do things, but will they do them when the world needs them to do it? And that's the kind of measure of whether somebody is capable or not. We're really assessing their willingness to perform tasks. Okay? Performance-based assessments are also called situational assessments. What's their capacity to problem solve? It's something we need to ask ourselves and discover. We want to increase citizenship practices. Okay, so anything that's civic involved. Assess for readiness within content context. So don't assess whether somebody can tie their shoes if you don't have shoes present. That doesn't make sense. These are questions you need to ask yourselves when you're looking for assessment, when you're looking for readiness. What does the task require? How much strength do they need? Do they need to make a decision? Do they need things? What is the social demand? What is the mental demand? These are all things to break down when you're creating your response to whether or not people. What is the performance base of this task? Okay. At the end of the functional needs and strength assessment, you should know what's in the person's repertoire. Okay. At the end of the functional needs and strength assessment, you should know what's in the person's repertoire because you kind of broke down and you unpacked what they are and what they got available to them to use. Questions you want to always ask yourself is, do they need more practice in order to get more effective? Do their symptoms impact their ability to be successful? These are all assessments. The environmental assessment, which is very important, is this the right place to do the assessment? When you're selecting your assessments, you want to think about relevance. Is it aligned to the goal? Think about feasibility. Do we have the time, materials, resources to assess this? Think about utility. Is the data going to be useful? Does it drive change? Are we using this data, or is it just for collecting purposes? Think about is this evidence-based? Meaning, is there some proven model as to why this is something we should be doing? Make sure the staff is prepared to assess, okay? So have they been professionally developed with the test? Do they know how to administer the test? Try not to overwork the client. So if you can, get it from the chart. Don't ask them questions that you can get from a chart. You want to watch confirmation bias, meaning when someone is coming in and you've heard bad things about them, and then they sit down and maybe they're having a bad day, and then you confirm that, and now there's this preconceived notion that you have stamped on them. You want to check that. That's a bias. And you want to just be culturally aware and responsive. Does the person know the why? Do they know why they're taking this assessment? That's very important. Okay. You want to be mindful of the language that you use. You don't offend anybody. You want to practice taking the assessment yourself as a person taking the assessment so you can see what they're experiencing. This test is also going to judge your capacity to perform. So I can talk in the office, but I struggle in real life places, like with the grocery store, with the clerk. I can talk in your office right now, but I struggle at church. Assessment is the first phase of the psychiatric rehabilitation process. Assessment is all about figuring out their goals and their skills and supports needed to reach that goal. Assessments lead to evaluations. The measures of skills and the measure of symptoms show little relationship. It doesn't. Psychiatric rehabilitation needs to focus on describing client skills and environment supports in relation to their overall goals. The assessment should have an overall rehab goal, which is the interview. What do you want out of life? A functional assessment, and then a resource assessment. So I know what the goal is. Now let's say, do you have the skills for that goal, and do you have the resources for that goal? But I got to name the goal first. Okay? The goal has come through from interviewing. The client must feel like they're a part of the goal setting. The client must have a major choice in this. Okay, so consumer choice is important. Client involvement is critical. Okay, so client active participating is critical. For the interviewing best practices, you want to orient. So you want to give instructions, give the objectives, then ask, okay, now what are we doing and why? Get that follow-up. Then you want to ask open-ended questions. The assessment should be clear, it should be brief, and it should be environmentally specific and focus on skills and resources. That's very important. And you want to include data that helps the client understand their results at the end of the day. So your data should be friendly for people to understand, accessible. Assessment should measure skills and supports. Assessment should measure skills and supports. The symptom diagnostic instruments, that's measuring the health status of the person. Health has begun to be an important part of the screening process. Physical health is a serious problem with our mentally ill, and we need to help that. Functioning in itself refers to the activity or the performance. So functioning is performance in particular domain. So the psych rehab functioning focuses on behavior, because that's what we're going to see, right? The degree of difficulty. We use the DSM-5 as a function assessment on people with disabilities. It's a 5-point scale. The 7 points ranging from minimal to optimal, depending on what that function is. But there are various skill assessments that we use. Environmental skills, community living skills, independent living skills. These are all different surveys throughout the time. At the end of the day, you must establish a trust-based relationship, right? You must have good interpersonal skills. You must be good at bringing the client into the assessment process. And you must drive, and the client's goal should drive the nuances of the psych rehabilitation assessment. Okay, so the assessment is based off of the goal. One of the biggest components that I think we need to be using is peer support. Okay, peer support specialists, they recognize their self to help others and do the same. They ask a lot of questions and get a lot of opinions. They're sincere. They're not oppositional. They do their time with their people. The psychiatric rehab work can be done through it can be done through a peer specialist. It should be, because those are the most effective, to be honest. People love to be around people that have been through the same thing they went through. The peer support specialist can be more on hands with them. They can understand their own experiences in the mental health system because they've been in the mental health system. Those peer support people, and just us in general, we need to be using person-centered language. What is that? Person-centered language is all about respect and dignity. Okay, how we form our language matters. How we verbalize and write to our clients matter. Okay, so the power of language is huge. That's how humans communicate, through language. So when we talk about this recovery, we're talking about describing life for someone living with a mental health diagnosis. What do you want to work on? What's really important to you? Right? That's what we're here for. Okay. You got to put that person in the driver's seat. They're in the driver's seat of their own recovery. Okay. They need to always know that it's about the journey, it's not about the destination, right? And the treatment plan, which is also best known as the recovery plan, is created with the team to map out the plan moving forward to attaining the goals. The treatment recovery planning meetings is every 6 months, collaborative as anyone can be. Can you suck it out and plug it up, charge it? Every 6 months, collaborative. Anyone can be set up to support the said person if that treatment plan is done the right way and is done to fidelity. The psychiatric rehabilitation process first is assessment, which is assessing and developing readiness, setting an overall rehab goal, the functional resource assessment. Second is planning. Third is intervention. And then the fourth step is this continuous monitoring. Questions you can ask yourself is, how dissatisfied is the person with their current situations? Like, do they believe that change is necessary, positive, and possible? That's very important. Psych rehab work is messy work, okay? And it's not always linear, as we talked about. Advanced directives in psych rehabs help people in situations to provide that tailored support when times are within a crisis. So the advanced directive is a tool or a document stating how to help the person when they're in a crisis. Okay, we want them to go from professional provider services to more natural community supports. I'm always driving my people to independence, regularly checking on their progress. So that's diagnosis. We talked about planning. Now let's talk about interventions. Interventions, the goal is for people to need interventions less and less and less and less, okay? Recovery is a lifestyle. Your identity is not your diagnosis, okay? So that's something that we need to know. Recovery is a lifestyle. Identity is not diagnosis. You have different types of interventions, like service interventions, meaning what do we do as practitioners to support recovery work? And then we have also interventions as far as skill supports, engaging motivation, assessment, and planning. The meat of our work is interventions. That's what we do, okay? The success rate of an intervention is mediated by the person's motivation to learn the skill, as well as the degree to which the person was involved in the assessment planning process, linking that work to a goal. One more time. The success rate of an intervention is mediated by the person's motivation to learn the skill, as well as the degree to which the person was involved in the assessment planning process, linking that work to a goal. Okay? Skills and supports equal success, right? Skills mean I can, I do, I'm help doing. Plus supports, filling that skill gap, equals success. Right? Interventions. Interventions can be skills, which is the heavy lifting is on them, right? The locus of action is on them. Resources, supports, they're getting that external support, or environmental modifications. Those are all interventions. I intervene through skill development, I intervene through resource and support, and I intervene through environmental modifications. Skills are what they're learning, right? That's what they're learning. That's the locus of action is on them. That's their skill development. Um, Skills can be learned through experiences, through modeling by me, and through training. As you know, modeling is just demonstrating the skill so that they can have a live model. A great intervention, a great skill building tool is role play. Role play is a great tool for practicing. Okay, some examples of skill teachings are establishing a routine and naming it, discussing the steps, breaking it down, modeling use of the skill, so like a direct show and reveal. Role play, which is just a practice in that bat at practicing that thing. You're supervising by a coach, makes a role play so that they can give good feedback. Providing positive and corrective feedback. Feedback is another skill teaching. It helps to make sure that they isolate what they should be working on. Consolidation, which is basically real world application of everything. The hippocampus is the part of the brain where learning memories are formed, right? It's in one of four lobes: the frontal lobe, the parietal lobe, the occipital lobe, and the temporal lobe. The location of the hippocampus is in the temporal lobe. When the hippocampus is activated, it's activated through telling, showing, doing, right? It's enabling learning to occur. The hippocampus looks like a seahorse. Okay. So emotional arousal stimulates learning. Okay? Emotional arousal stimulates learning. Why is this important to me? That's emotional arousal. That's emotional stimulation. Why is it important to me? Okay? You must link the functional deficit to the goal is reimbursable as a skill. Linking the functional deficit to the goal is reimbursable as a skill. So the functional deficit may be wearing a pressed clean shirt to work every day. That's a deficit because you're not doing it. The function is wearing a clean shirt. The goal is to go to work. Well, in order to go to work, you need to have a pressed clean shirt. So that functional deficit, you need to work on that skill. So the skill work comes in based on the functional deficit that's impacting the goal. Okay, so when we mention the word resource or support, we are talking about a person, place, or thing, or an activity. Okay, resource support is a person, place, activity, or thing. Skill development is way more tough than providing resources, right? Resources is connecting somebody. Skill development is internal. Resources is external. Practitioner trainers are important and need professional development. You can't get into this work if you're not sharpening your sword constantly. If the skill is needed but the motivation is not there, what can we do? Well, we need to get an alliance, right? There's trauma, historical, negative exists with people, and maybe that's the problem between this person not working on their skill. The person simply needs to be motivated, okay? And in order to do that, you have to have a healthy relationship. So what are 3 keys to an effective healthy relationship? 1 is to be fully present with that person. Be empathetic, right? Being in that hole with them. 2 is monitoring and managing, keeping the relationship strong. And 3 is establishing goal consensus between y'all. Like, why are we in this relationship? Why are we here for each other? Motivation is a state of mind. It's a mindset. It can't be taught. Like, it's a state of being. So it can be influenced then. It's fuel for change. Motivation is fuel for change. We talk about change in 5 different ways. 1, pre-contemplation. Like, there's no need to change. You know, the decision to change is yours. I don't know if I'm ready to change. 2 is contemplation. Meaning, okay, I feel pretty positive about this change, the perspective changing. 3 is preparation. Meaning I'm committed. But I really don't know where to start, but I'm committed to making this change. 4 is action, right? I'm ready to be taught the skill. I'm ready. I'm in it. I'm doing it. And 5 is maintenance work. That's the routine work that makes the change applicable, and that's how you maintain it. Okay. In order to engage and influence motivation, You need to be attending to that person while they're talking to you, meaning you're showing nonverbals of active communication, of actively listening. You're nodding your head. You're mirroring and heightening what they're saying back to you. Orienting. You're stamping the why. Why are we having this conversation? Why are we doing this? And you can articulate back to me what the why is. Reflecting, meaning restating what people said and name it and use me as a mirror. That's similar to that heighten it. Eliciting change talk. So if someone doesn't want to do it, so then if they give you a number, you can say, so Steve, what would have to happen to make that a 7 or an 8? Right? How you doing today? I'm a 3. Well, what would have to happen to make it a 5? That's that change. That's eliciting change talk. And describe the next logical steps for that change. Now you're talking about really being intentional and really supporting them through that work. Another thing could be, you said you're on a 3. Well, why not a 2 or a 1? And what that also is doing, eliciting change talk. Let them know they're not where they are, right? It's not as bad. Why are you not at a 0? Also, how are you accompanying them? Shared decision making provides opportunity for them to learn as well. So it's just another at-bat with you. And you want to also facilitate discovery within them. So active participating. Skill learning can be aligned to self-exploration all the time. Now, maybe they're not ready, and that's where you want to assess development readiness, right? So you want to talk about their need, the desire to avoid negative outcomes, the commitment, the efficacy they have towards making the change. What options do we have available to us? As far as goal setting, is there a selection of a role in the environment that we want to live, learn, and work or socialize in? There's a huge impact of doing this with people, okay? People have all types of experiences with their diagnoses, and we can talk to them to find out what they use in their past life to help them be successful now. You know, for example, someone who hears voices, there's a shower radio story. Someone would never get in the shower because they kept hearing voices. Well, one of the nurses decided to just put a shower radio in, and then the person started taking showers, and they would mean their ADL goes. So it's such a simple resource support to fix people, but we got to just be creative and take the time to actually care to think about it. You know, as a psych rehab practitioner, we only really do a few things. We assess, we do crisis intervention, we engage, we motivate, we do service planning, we do skills training, we do we do resources and supports coordination, and we do relapse prevention. That's pretty much what we do. There are other areas that we can support people through supported employment, supported education, which is basically a response approach to people living with mental health diagnosis and they want to return to school, right? We want to shed the identity, that ego of the patient and have them take on the mask, the hat of a student, okay? They get an education of their choice. They can choose what they want to learn and where they want to go. There are 6 principles of supported education: dignity, self-determination, normalization, reasonable accommodation, skills and supports, and hope. Okay. Now with dignity, you just want to protect their privacy, right? And you want to enhance any personal dignity that you can. Focus on choice and independence. That's dignity. Giving people independence and treat them with dignity. As far as self-determination, you really want to promote their belief in themselves. You want to promote their self-choice. Active student participation will increase their belief. Let them be the one to set the goals, right? You are no longer a patient. You're a student. People have an immense amount of fear, but fear is false evidence appearing real. And you let them know that on the other side of fear can be failure or success. Then I promise you, you're going to be successful. With normalization, with supported education, you really want to give them the most least restrictive environment, okay? So you really want to promote dignity by not interrupting their normal day with check-ins. You want to integrate your service in a normal setting, so meeting them in a lunchroom as opposed to meeting them in the back of the classroom in front of people, right? And you want to debunk stigmas. Don't say mental patient. These are people living with this at the end of the day. And we want reasonable accommodations, okay? So we're not asking people to change their whole grade book, but we're asking for, an equal playing field for equity. We're asking for a silent room, a quiet room to study if I'm triggered by noises, right? Emotions need emotional ramps, just like wheelchair people need physical ramps, and those need to be given. Or example, that could be IEPs, 504s, in-school supports, all of those things, just to increase access. As far as skills and supports, student skills and environmental supports, skills drives change, not symptoms, okay? Educational outcomes are most important. We want to focus a lot on social, emotional, intellectual skills. We want to focus on work adjustment skills, punctuality, attendance, taking directions, maintaining a pace. These skills that make people to be beneficial people and part of society, like everybody else. Okay. When it comes to education, we use a choose, get, and keep, meaning you choose the identity school of your choice, you get enrolled, and you keep in there by maintaining your GPA. Okay. Those are the supports. And now hope, I mean, everything begins and ends with hope. We could have started it with hope, and we're going to end it with hope. Hope is pretty much the most critical ingredient. Every step towards your goal creates hope. Going to a class creates hope. Going as a group creates hope. We create hope by sounding interested and genuinely caring about what people are talking about. Healing and recovery will slowly come and settle on this imitation of itself, which we have been offering it. Hope. Very important. Okay, 35, 7 more pages. Let's talk about motivational interviewing. All right, now we're going to talk about motivational interviewing, which is a really good tool to use to get someone to make positive changes for themselves. Motivational interviewing increases their efficacy for self. It helps them make a change in an established routine. Motivating people to make behavioral changes is work, right? And that work can help them adhere to their treatment. It only takes about 10 to 15 minutes for motivational interviewing. It supports behavioral change. It's a lifestyle change intervention, and it's an intervention to motivate change in the person. The deepest impact follows after the motivational interviewing. It's a directive, client-centered counseling style approach for eliciting behavioral change by helping clients to explore and resolve ambivalence. Ambivalence meaning I'm stuck between two things. I know I want to do this, but I'm not. I'm stuck. Like I know I should do better, but I just can't. This helps clinicians. This motivational interviewing helps them, right? Because it's promoting collaboration also, and you use logic to overcome ambivalence. You emphasize the importance of the thing to overcome ambivalence. You turn up the volume to overcome ambivalence. You confront out of concern to overcome ambivalence. Like I'm talking to you because I know this is important for you. I know this is good for you, so I want to know why you're not doing it. Readiness to change is not static. Okay, it's dynamic and can shift at all points. Someone can be ready today and then not ready tomorrow. You need to get these people to name the positive parts of their recovery. Get them to focus on the positive parts of their recovery, which is going to increase their efficacy. The spirit of motivational interviewing is a symbiotic relationship. Okay, it's all about the feeling of the people. Okay, Double Trouble is a self-help group that people use. It's for self-help. Okay, there's 4 core principles of motivational interviewing. First is expressing empathy. So providing, you got to communicate that you care and you understand their experience. The second is develop a discrepancy. So you kind of need to highlight the gap between what their current action is versus their desired skill goals. Have them name it though, not you. Have them name that gap. The third thing is to roll with resistance. You know they're going to be pushing back. You know they're not going to want to do anything. Do not teach. Do not coach. Do not push back. It's all about them. And then last is supporting self-efficacy. So you're just constantly pouring in love and belief that that person can and will change. You're their biggest cheerleader. You're their biggest support. You got their back. Now, the skills of motivational interviewing is reflective listening, so mirroring deepening, right? Accuracy of knowledge to understand that you know what you're saying and you can amplify what they're saying. Asking open-ended questions, which keeps that dialogue open and can really steer them to change. Why is that important? Why is that important? Stuff like that. Direct affirmations. You are dope because you are doing work that I know is hard, but I appreciate what you're doing right now, and you appreciate what you're doing. You're going to build rapport. It increases that person's self-efficacy. And then just summary statements, right? Wrap up what they say in 1 or 2 sentences. But then you can also ask them, but what else? Is there anything I missed? Because you really want to make them feel like they're heard. That's very important. Okay. Next page. When you're providing information to people, you want to do it on an ask, provide, ask basis, which is ask the person what they already know about this. So if you're like, to give them respect and dignity. If you want to introduce something, you don't just assume that they don't know. You want to ask them, hey, what do you already know about bipolar? I have some info about it. Can I share it with you? Can I share this info with you? Get permission. Provide it. And then you just ask, what's your thoughts to what I just provided you? What's your thoughts to what you just learned? Give your lots of thoughts on it. What are your thoughts on it? That's how you build up that thought process, that relationship, and also how you build up, the ability for information to be disseminated to patients in the least restrictive way. There are 6 evidence-based practices for helping people in a situation. You got the illness management recovery, the assertive community treatment, family psychoeducation, supported employment, integrated treatment for co-occurring disorders, and medication management. Those are all based on SAMHSA. One of the major keys here is just pretty much after every motivational interview is to always offer reflections. What do you think about that? How does this feel? What do we do? Why do we do it? Why is this important? Getting that deep level of understanding, that deep level of thought is critical. When we talk about evidence-based practices, we're talking about practices that have been backed with research, proven data, right? If there's no data prior, then it's called an emerging best practice. Governing bodies have resource kits to determine which is an emergency and which is a best. But you want to avoid the single model trap, that there is no magic model for all people with serious mental health illnesses. That's a trap. Don't fall into it. The single model restricts consumers' choice. It makes providers deciding what's best for them, for the people. And that's not good. We want customer satisfaction. We want diversity in our rehabilitation services. We want person-centered approaches. We want to create a strong infrastructure so people can have multiple models to tap into if they need support. We also want to have competencies around multicultural understandings of our world we live in. I mean, at the end of the day, diversity is broad. Multicultural diversity is different than multicultural. Multicultural talks about the cultures and the subcultures of a society, where diversity can have people completely different. We want to focus on the culturalisms of people. So maybe eye contact is different to this culture and that culture. Handshakes are different from culture A to culture B. In culture A, you talk about the dead. In culture B, talking about the dead is making you crazy. In culture A, maybe I use a lot of proximity. In culture B, I don't. So you got to figure out what the culture nuances are for where you are so that you can assimilate. And assimilate means assimilate means those are doing it and other cultures have accepting it as a new normal. Meaning you're not from the outside looking in, now you're part of us and you're just part of the new normal. Acculturation more is like they're dressing like, talking like, acting like, walking like. But you're not really, the people haven't accepted you. Okay? So it's like an animal is released back into the wild and they look like a duck, they talk like a duck, and they act like a duck, which means they have acculturated in that society, but none of the ducks have quacked at them or brought them into their duck groups. So they haven't assimilated yet. Eventually they will assimilate, and then when they're in those groups, now they have assimilated. So that's the differences. Okay? We just need to find out at the end of the day kind of what is considered normal in that community, because that's our baseline. What's normal in that community? That's our baseline. Okay? So that was good. Now we're moving on. Advocacy. Advocacy is a focused and purposive effort to create change on behalf of or with specific populations. Okay? You must fight for your people. Okay? We must use advocacy to change policies. We advocate to create a just society in which all people have equal opportunities to chase goals. We advocate so that we can ensure programs are accessible effective, appropriate, flexible, adequate, comprehensive, and efficient. We advocate to protect existing individual rights and establish new rights and entitlements. We advocate to eliminate the negative and unethical impact that institutions, peoples, and programs have had on people since the beginning of time. We advocate to ensure that the least restrictive, least intrusive intervention is being used at all times. Okay? Recovery is important. Advocacy helps that. All right? Now, the targets, and advocacy always has a target. What are you trying to change? What needs to be changed? Then you actually have to have the tactics. What is actually going to happen? You know, we could testify at hearings. We could hold a press conference. We could use social media. We could write a letter. You know, that's the tactic. Then you got the campaign, which is a full initiative, right? One step towards the goal, rallying together, social justice. You know, you really want to identify the issue and a hopeful outcome. You want to state your case and propose a solution. Then you want to build a base of supporters based on what your solution is. Then you want to create an action plan with those supporters. Then you want to make sure you take the least conflictual action needed to accomplish the objective. You don't want to make it difficult. And you just want to document everything so that you can have a running record of whatever you say. Okay? Advocacy, at the end of the day, is all about making a meaningful changes in people's lives. So that's it. You can do self-advocacy, which means you identify needs and you speak up for the person. You can do agency advocacy, where you make changes within the agency to help people. You can do legislative advocacy, where you respond to budgets or laws addressed, and you talk to the school board. Or you can do community advocacy, where you're educating the public who are oppressed or uncared for. You know, at the end of the day, it's all about recovery, and it's all about you being an advocate for our people. A part of that is having an understanding of shared decision making, because you know you don't want to advocate for somebody and you don't know who they are. You have no understandings of what they want or don't want. Okay, so part of the shared decision making process is focusing on recovering a life after a mental health diagnosis. Okay. That's very important. Recovering a life after a mental health diagnosis. So from the client's perspective, they want choice. They need to have more empowerment. They want, determination for what they want to do. And when we're unpacking that, the client and the practitioner are co-investigators. They're collaborators in this. Okay. A lot of patients may use personal medicines, which is self-described non-pharmaceutical strategies to help themselves. If it's working, it's not illegal. Let's keep doing it. Let's unpack it, right? Shared decision making allows for practitioners to be expert collaborators. It also allows for people to be heard. With medical management, 50% or higher of people don't adhere to their medication. That's a problem, okay? And it's a problem because people look at medication as this paternalistic lack of an appreciation of the importance of the client's role in the decision, okay? Compliance with medication comes with more than just an insistence. There needs to be two experts for the shared decision-making model. Expert one is the client, and guess who the second expert is? You. But the first expert is a client. So at the end of the day, you should not be having any decisional conflicts, okay? Be mindful when you're doing this shared decision-making process, all right? Now, we want to rethink rehabilitation. What we've been doing in the past is in the past, but we want to rethink it, okay? At the end of the day, freedom and choice is paramount, okay? The soil is the freedom. The seeds are the humans, and oppression is a drought. The soil is freedom. The seeds are humans. Oppression is a drought, okay? People with disabilities feel oppressed, right? At the end of the day, oppression forbids our becoming. There are over 43 million people with disabilities. And no one needs to settle for a life of coping. No one wants to hear a prognosis of doom. Disability checks are not enough. $700 a month for food is not enough when I got to buy soap and dish detergent. Okay? It's cheaper to provide in-community resources versus going into a nursing home. So we want to meet people where they are. We want them to lean on their natural supports. We want to empower them to use their community as their recovery. Stop the vicious cycle of psychiatric rehabilitation abuse. Like, stop it. We know when people aren't happy. We know when people are experiencing that scream. The language of a scream is a universal language. We want what you've got. That's all it is. We want what you got. You got a home, we want a home. You can walk to work, we want to walk to work. You can come in and go as you please, we want to come in and go as you please. We want what you got. Okay, 4 more pages. At the end of the day, we walk in hope because we've been through tough times. That's why we walk in hope. Recovery means getting the life I want to live. For some people, recovery means having a job, a paycheck, and a date on a Saturday night. That's recovery. It can mean anything for any people. But I'll tell you, the prognosis of doom is worse than the psychosis event itself. Human resilience does not end at a diagnosis. It begins. Okay? And again, we still have those psychiatric, those advanced directives, right, which gives a competent person specific instructions or preferences regarding future mental health treatment. It helps give preferred treatment if a consumer isn't in an episode. Okay? So it's just a tool that we use to enhance the consumer's voice in their own treatment. Sometimes the advanced directives can be beneficial, sometimes it can't. One of the pros is it empowers people with a voice in their care, it enhances continuity of care, it assists in crisis de-escalation, it encourages treatment, collaboration, but then it could be some cons too, because there's not enough staff education given, or we can't access them at 24/7. Maybe you need it in 3 a.m. on a Sunday. Ain't no staff. There's not enough consumer education given out. So how are we teaching our clients who create this about it? There's sometimes just difficulty figuring out what intervention should you use during this crisis. So even though it tells you, there's still other options you can use that can create kind of those gaps of choice in that moment. Which is why they should be updated regularly, because we want to make sure we have the most relevant, up-to-date interventions for our clients. It doesn't matter who you are. If you're a stakeholder, whether you're a family member, a practitioner, a nurse, a case manager, you're a stakeholder and you need to have education on that client's advanced directives, period. We live in a country where mental health and voting is a big thing. People want to not give people who have mental health diagnoses the right to vote, like they don't want to give certain other people in our countries the right to vote. But voting is a fundamental USA right. It's fundamental. People disenfranchise our people from voting, and that's not okay. Service providers like nursing homes cannot bar nor deem incompetent in regards to somebody voting. Banning people with disabilities from voting takes legal document from a judge, nobody else. You can't stop me from voting. Okay? People with disabilities have a right to get help with voting. Help, not persuasion or coercion to pick somebody. Okay? The United States Constitution protects this right to vote. All right? So, yeah. One of my favorite parts is the role of religion and spirituality in recovery. So we're talking about the body, the mind, and the spirit, right? And religion is a belief. It's a community under a structure, authority figures and rules and regulations are all right. Spirituality, however, is different. It's more personal belief and practices. It's like making meaning of life. It involves your faith, your hope, and your peace, okay? As a mental health patient, my brain can be sick, but I have a healthy spirit. My brain is sick. My spirit is healthy. And that's the difference, right? People come to the United States. People came over here to avoid the religious oppression that they felt in their countries, right? In 1492, when Columbus first came to America, it was documented saying, we can make these natives into Christians, okay? There's a huge church separation of church and state that happened. The great divide between the secular world and the sacred world, bridging the gap between mental health professionals and exploration of religion. One of the greatest merges of religion and mental health is AA. AA has been proven to be the most successful group dealing with recovery out of anywhere in the world. The 12 steps work, right? In the 12 steps, there are a lot of prayer and spirituality in those 12 steps. At the end of the day, mental illness, they call it the great robber because it can diminish your idea of your purpose in life. Mental illness can diminish your idea of your purpose in life. Religion helps a person overcome that. Spirituality helps a person overcome their disabilities. Okay? Religion and spirituality are the fourth leg of recovery. Think of a table. A table with 3 legs won't stand. That fourth leg is religion and spirituality. Okay? We need to do a better job at debunking and unearthing the negative messages of a punitive God, right? Some people grew up in churches where they looked at God as a big bully and he'll send you to hell and destroy you. That's not God. God is love. God is understanding. God is coming back after mistakes. God is with you no matter what. We need to debunk this idea of a punitive God. Ways we unpack people's relationship in the spirituality is you just always ask and be curious. Are you currently involved in a religion? Have you ever attended church? Why'd you leave? Questions like that will prompt you to understand what this person's background is and kind of how to have access into that fourth leg of recovery, which is religion and spirituality. And if someone doesn't, want to rock with Jesus or God, then you can just simply ask them, so what do you turn to when things get out of control? What do you turn to when things get out of control? Because then that's that higher source, right? And then we want to start creating spirituality groups. And you don't have to call them that. You can call them mindfulness groups. You can eat mindfully. Eating mindfully is taking one bite, and slowly chewing and tasting the breakdown of the ingredients. That's eating mindfulness. So you can practice mindful in everything you do. It's just being intentional. Journaling is mindful. Breathing is mindful. Exercising with intentionality is being mindful, meaning you're keeping your back straight, you're doing it the proper way, you're really taking your time with it. That's being mindful because you're in it, you're focused, you're in the moment. Your state of being is here. Practicing loving kindness is that as well. So those are things that you can do to increase the connection to that fourth leg of recovery. Ask those people questions. What keeps you going? What brings you peace? And then they'll unpack that and you'll get more information. 2 more. Right? Now I'm going to talk about supporting veterans through comorbidity. Homeless veterans are a concern. Okay? You served our country, you did everything you had to do, and then you come back home, we can't take care of you. So that's a problem. Comorbid means that there's a psychiatric disability and a medical condition present at the same time. Okay? Homeless people, more times than not, generally have untreated health conditions and untreated health problems. Homeless veterans need support. For the longest, psych meds have shown that most clients won't take them, and rather not, out of preference to more natural cures. Some veterans on the street can't even get that because they're homeless, right? So we need to do a better job of supporting our veterans and making sure that they take into account. Now, as far as the understanding about relationships and psych meds, know that 50% of those given psych meds actually take them. So the most important person is the practitioner-consumer relationship because people aren't even complying with their medication. Okay? So how can a frontline practitioner deal with this problem? Through psychoeducation, through peer support, through family interventions, through cognitive treatments, through behavioral modifications, through behavior tailoring techniques, through community-based supportive services. These are all ways to deal with that problem. But you should also, when you're trying to figure out why somebody's not taking their medication, you should also try to consider what are the cultural differences that you don't know about. You want to inquire about their personal preferences. We need to redistribute the power in our mental health systems to go to the consumer. We need to switch to a recovery-oriented model focused on the consumer. The first step in medication compliance is relationship and rapport. Relationship is the floor. So if people are not adhering, then that means you need to create some more positively meaningful events and situations for you in their relationship. Now, if relationship is the floor, then there are a lot of ways to help the client. You can empower them by asking them questions, which gives them agency. You can help them write down their goals, and you can be an advocate for them. You can look at their medication and check on side effects with them. The nurses can do role plays with it, which helps the patients deal with like tough conversations. You could teach medication strategies, and you can talk about the medication. These are all ways to help the client. And at the end of the day, we are all about wellness. What are we about? Wellness. Wellness is huge. And May is Mental Health Month. Okay? Mental health is just as important as physical health. Wellness is all about being in the moment, right? It's about having good habits. You're sleeping enough. You're eating well. You have meaningful, productive lives in your community based on the things that you set out to do to attack those 8 areas of wellness. 25% of all people experience a mental health diagnosis in their lifetime. 1 out of 4 people will experience a mental health diagnosis in their lifetime, which means 25% of the world needs to have support with mental health. That's huge. That's 8 billion people. That's 2 billion people right now. Okay? Recovery is a linear journey with ups and downs. Okay? So we really need to have our peer, we want to have this idea that this is not going to be something simple. One way we do that is with our peer support, our peer warm lines. Okay? We have people that are peer supporters that we can call in and get access to that have great insight into recovery that we can now trust. We need to focus on access to care when people aren't in a crisis already. We need to focus on access to care when people aren't in a crisis already. Okay? Last but not least, the most powerful thing is peer support. Peer support. Peer support means people like you, look like you've been through what you've been through, but supporting you through. It feels so much better. It feels so much better. And in order to change these huge systems, we need to change agents. And guess who's the change agent? You are. Okay? So when we have a person-centered approach and when we use motivational interviewing for people, then we become change agents. When we use person-centered approaches and motivational interviewing, we become change agents. When we use person-centered approaches and motivational interviewing, we become change agents. And those change agents can change the systems. Small, incremental changes can have a large impact. Small changes can have a large impact. Think about something so small as washing your hands. That can impact your whole health. And that's so small, okay? So when we think about wellness, we're talking about mental, physical, emotional, spiritual, right? But not only those 4. There are other 4 that's under that, right? There's also the social, the financial, the intellectual, the environmental, and the occupational. So I think we actually got mental and intellectual together. Those are 4 the same. So mental and intellectual are together. So your mental health, your physical health, your emotional health, your spiritual health, your social health, your financial health, your environmental health, and your occupational health are so important. Every day you need to be doing something out of all of those 8 things. If you do all 8 things every day for a week, I promise you, you will feel that much better. You will feel so much better. Okay? And it's a strength-based approach, which means we're looking at what are we strong at in that area and what are we going to improve. We're not looking at what are we not good at to make ourselves feel bad. And at the end of the day, we use a WRAP, W-R-A-P, Wellness Recovery Action Planning. WRAP is used to help people feel better, which used to help people feel better and to connect them to resources. So you want to create a plan off of the 8 domains of wellness, okay? At the end of the day, we have a nation where people can and do recover. Mental health is a public health issue, just like obesity, just like high blood pressure, just like diabetes, just like HIV. Mental health is a public health issue. Mental health is a public health issue. Okay? So, behavioral health conditions lead to the most deaths in our society. It's a huge public health issue. Behavioral health conditions lead to the most deaths in our society. 8% of United States Americans 12 and up have had a substance abuse encounter. Marijuana does impact on your health, especially on our youth. Okay? Prevention is critical. We need to reduce the dependency. Right? Heroin and binge drinking have gone up tremendously. Addiction is a disease. Addiction is a disease. And recovery is a life beyond your wildest dreams. And you can make it. You can get that. Remember the stages of change. Pre-contemplation, contemplation, preparation, action, maintenance. And that sixth one is relapse, because no one's perfect and we're going to fall again and you got to go through it again. So keep a growth mindset. And remember, people with mental health issues die on the average 10 years earlier than everybody else. So that's a problem. And that's why this needs to happen. Recovery reduces recidivism. Wellness can help us live longer. Recovery reduces recidivism. Recovery reduces recidivism. People with mental health issues die on the average 10 years earlier than other people. Psychiatric rehabilitation is necessary work. It's a recovery work. And it's work that we all can do together. Thank you.